Dear colleague, good afternoon. First, I would like to thank the Congress organization committee and his president, Professor Youssef Ben Amr, for their invitation and for giving us the opportunity to discuss, to share and to discuss the management of heart failure, HFpEF. I'm so pleased today to co-chair this session with the well-known expert in heart failure, Professor Bertrand, President of HFpEF Association, and Professor Magdi Abdelhamid from Egypt, past President of Egyptian Society of Cardiology, and of course my dear colleagues, Professor Ikram Kamoun, Professor Leila Abid, and Professor Mariam Drissa. So in the first, I will invite Professor Magdi Abdelhamid to speak about risk score and biomarker in HFpEF.
Good afternoon, everyone. First of all, I'd like to thank Professor Youssef Ben Amr, the president of the Tunisian Cardiac Society and Cardiothoracic Surgery, and all board members of the society for the kind invitation, and congratulations for this great, successful event. And as a chairman of the EC Task Force North Africa, Middle East, I'm very happy that we have a joint session with the HFA, European Society of Cardiology, in the presence of Professor Marco Metra, the president of the Heart Failure Association. So this is very important session, which is usually with the different national cardiac societies, with the EC, we are doing these joint sessions. So my assignment today is to give a short talk on roles of scores and biomarkers as a risk stratification in HFpEF. This is my disclosure. We know that on 2021, the new universal definition of heart failure have been released based on this definition. It is symptoms and or signs of heart failure caused by structural and or functional cardiac abnormality and incorporated by at least one of the following: high level of natriuretic peptides or objective evidence of cardiogenic pulmonary or systemic congestion. And of course, we know that symptoms and signs of congestion and abnormalities can be detected by echocardiography, such as an ejection fraction less than 50%, E over A prime more than 15, and the others. We'll see later how to diagnose all these cardiac abnormalities. And according to the HFA-EC guidelines 2021, heart failure with preserved ejection fraction is defined as symptoms and or signs of heart failure with an ejection fraction 50% or more, with an objective evidence of cardiac structural and or functional abnormalities consistent with the presence of LV diastolic dysfunction, high LV filling pressures, including high levels of natriuretic peptides. This is compared with HFrEF, which is well known when the EF less than 40%, or with heart failure with mildly reduced ejection fraction when the EF is 41 to 49%. And we have to know that we are in the era of increasing prevalence of HFpEF. And this is expected due to aging of the population, due to increasing comorbidities of HFpEF, such as high blood pressure, obesity, diabetes, proper treatment of coronary artery disease, increasing prevalence of atrial fibrillation. So all these causes of HFpEF lead to increase in HFpEF prevalence by about 37% when you compare 1985-1994 to 2005-2014. The prevalence of HFpEF is rising. And unfortunately, the mortality of HFpEF it is more or less the same as HFrEF. That means that if the ejection fraction 50 or more, this not carry a good prognosis always in HFpEF, because it is a disease of comorbidities, and mortality, which is most commonly due to non-cardiovascular causes, is high. So mortality still in HFpEF is increasing, and it may be equal to HFrEF. And we have to expect the presence of HFpEF in the presence of age above 70 in men or women, overweight or obesity, diabetes, physical inactivity, hypertension, atrial fibrillation, ECG abnormalities, high level of NT-proBNP more than 125 picogram per milli, or PNP more than 35 picogram per milli. In the daily clinical practice, when we have patients have symptoms suggestive of heart failure, like shortness of breath, fatigue, peripheral edema, the presence of these symptoms, you cannot differentiate between HFrEF and HFpEF. So the symptoms alone cannot differentiate between HFrEF and HFpEF. And the challenges in the diagnosis is related to the ejection fraction. Echo in a patient's complaining shortness of breath, but the ejection fraction looks normal, 60%. NT-proBNP may be low. Symptoms might be shortness of breath caused by obesity, for example. High LV filling pressures might not be detected at rest and only detected with exercise. So we have two important heart failure with preserved ejection fraction diagnosis scores which can help in the daily practice to diagnose HFpEF. The first one on the left is it is H2FpEF score based on points. If you have a body mass index above 30 kilogram per meter square, you will get 2 points. High blood pressure, 1 point. Atrial fibrillation, 3 points. Pulmonary artery systolic pressure above 35 millimeter mercury, 1 point. Above the age of 61, high LV filling pressure detected by E over E prime more than 9, 1. So a high score indicates that shortness of breath most probably caused by HFpEF, while a score of 0 or 1, shortness of breath, cannot be considered a criteria of HFpEF. On the right, it's more complex or more advanced score by the HFpEF score based on major and minor criteria. Major criteria based on E over E prime more than 15, septal E prime less than 7 centimeter per second, lateral less than 10, tricuspid regurgitation velocity more than 2.8. These are major criteria by echo, so you'll get 2 points. Left atrial volume index above 34 milli per meter square, increased LV mass index, high level of NT-proBNP, sinus rhythm compared with atrial fibrillation. In the presence of AF, high levels of NT-proBNP is indicated. While a minor criteria, a less value for E over E prime, 9 to 14, GLS less than 16%, left atrial volume index 29 up to 34, LV mass index above 115, and relative wall thickness 0.4. So again, a high score indicates a high probability for diagnosis of HFpEF. In case of borderline risk score in a patient still have symptoms suggestive of HFpEF, we need to do evaluation with exercise, like exercise echo or stress echo. And the idea is to look for these parameters with exercise, which might be normal at rest. So E over A prime more than 15, or TR velocity more than 3.4 meters per second. If it is present, this indicates a probability of HFpEF is increasing. And on the other hand, if still the diagnosis is doubtful, we might need to send the patients to the cath lab to estimate the pulmonary capillary wedge pressure, which it is above 50 millimeter mercury at rest. This goes with HFpEF or with exercise more than 25 millimeter mercury. And this slide summarizes the echocardiographic parameters of estimating a high LV filling pressure based on peak TR velocity more than 2.8 meters per second, E over A prime more than 14, left atrial volume index above 34, and left atrial reservoir strain less than 18%. And this is a classic example for patients having HFpEF, LVH in patients having hypertension, complaining of shortness of breath, and peripheral lower limb edema. Probably a diagnosis of HFpEF was considered. He has an LVH detected by increased septal and posterior wall thickness. And if you look for E over A prime, it is 18.5, which is more than 9. And again, decreased GLF, tricuspid regurgitation, pulmonary artery pressure, systolic pressure is the maximum 35 millimeter mercury, increased left atrial volume index, which was 65. So all these parameters go with the diagnosis of HFpEF, and this slide summarizes again how to consider these parameters in addition to biomarkers to diagnose HFpEF. This slide indicates when we should consider to send the patients to do an exercise echo or diastolic stress test. And the criteria to diagnose HFpEF, when you have an E over A prime more than 14 or septal E over A prime more than 15 with exercise, peak TR velocity more than 2.8, septal E prime less than 7 centimeters per second. So this slide summarizes how to diagnose HFpEF in patients complaining of shortness of breath. The probability of having HFpEF should be considered first. Proper clinical evaluation, hypertension, obesity, diabetes, etc. Doing an electrocardiogram, chest X-ray, echo, and estimating NT-proBNP level. And according to the probability of the score, it is a low score, rule out HFpEF. High score indicates HFpEF, and the very high risk score indicates a bad prognosis also at the same time, while an intermediate score, you need to do more confirmatory tests by diastolic stress test or in the cath lab to estimate the wedge pressure. So unfortunately, 30% of patients have near normal NT-proBNP level, so a lower level of NT-proBNP cannot rule out a diagnosis of HFpEF, and this slide shows a different phenogroups for HFpEF. On the left, this is PNP deficiency syndrome, which is seen mostly in obese patients who have near normal NT-proBNP level in spite of having a diagnosis of HFpEF. In the middle, this is an extreme cardiometabolic profile, and on the right, the most severe form associated with right ventricular failure and the cardioabdominal renal syndrome phenotype. And this interesting paper published 3 years ago for the prognosis of patients having lower levels of NT-proBNP. Even if you have HFpEF with lower NT-proBNP level, the prognosis is still not good. And this slide summarizes the difference between the control group without HFpEF with NT-proBNP less than 125, and HFpEF with NT-proBNP more than 125 picogram per milli. And if you look for the survival is lower, even with lower NT-proBNP level compared with the control. And of course, with a high level of NT-proBNP, also the prognosis is not good, associated with more RV remodeling and impaired RV function, in addition to increased secondary mitral and or tricuspid regurgitation. So they concluded that patients with HFpEF and normal natriuretic peptide level have increased mortality and heart failure readmission compared with subjects with non-cardiac dyspnea, heart failure, and HFpEF with elevated versus normal NT-proBNP level is associated with worse RV function, more secondary valve regurgitation, and the impaired cardiac output reserve. The phenotype of HFpEF is very important to look for the prognosis. So the prognosis is not good in the presence of a lot of comorbidities. So if you have hypertension, obesity, diabetes, chronic kidney disease, COPD, the prognosis for HFpEF is worse, and the mortality in those patients usually is due to non-cardiovascular causes. So identifying the phenotype is important, especially HFpEF with obesity, because we are in the era of novel drugs which improve the outcome of HFpEF in obese patients. Mortality is high in HFpEF, especially in obese, and this slide shows that all-cause mortality and the cardiovascular mortality in HFpEF in obese patients is worse compared with HFpEF in non-obese patients. With this, I finished my presentation. Thank you for your attention.
Thank you, Professor Magdi Abdelhamid, for your excellent and clear presentation. I think I will let the question and in the end of the session.
So it is a pleasure for me to invite Professor Layla Abid. She was the head of the cardiology department of SFAX. She was the past president of STCCCV and actual coordinator of the heart failure group. She will talk about imaging-guided diagnosis and therapy in HFpEF.
Thank you, Dr. Drissa. Good afternoon, everybody. It's my pleasure to be with you this afternoon in this interesting session, common session with HFA, European Society of Cardiology, and we are very pleased and honored to have with us Professor Marco Metra, the president of HFA, and also Dr. Magdi from Egypt. And it's a pleasure also to co-chair this session with my colleagues. So I will, and also I'd like to thank the board of the Tunisian Society of Cardiology for the invitation, for the nice and wonderful meeting. And it's my pleasure to be with you to talk about imaging-guided diagnosis and therapy in HFpEF. So I will start, I don't have a conflict of interest. I will start with two cases, two daily practical cases in our daily practice about two Mrs. They have the same name, Mrs. Sania, and they have the same age. The first one has hypertension. The first one, the obese one, has hypertension, diabetes, obesity, BMI is 31, and the second one has chronic kidney disease, and the BMI is 24. She also has canal tunnel syndrome. So the question is, for these ladies who have the same name, the same age, they are suffering from shortness of breath on exertion, on exercise, and they have also atrial fibrillation. And the atrial fibrillation, and then the exam was normal. We have only high blood pressure for the first patients and normal biological tests, unless NT-proBNP was high for the first one, 1,000, and the second one, 50. For the obese patient was 500 NT-proBNP. So the question is, in our daily practice, do they have HFpEF? It is easy to confirm the diagnosis of HFpEF in these cases. So if we look at the European Society of Cardiology or SCC guidelines recommendation for the diagnosis of HFpEF, we have the same definition. It was presented by Professor Magdi Abdelhamid, the universal definition. We need to have symptoms and signs added to preserved ejection fraction more than 50%. But if we focus on the European guidelines, as you say here, with the focus here, we have European-wide, we need to have structural abnormalities and functional abnormalities. Structure, that means the enlargement of the left atrium and the left ventricle, functional diastolic dysfunction, and the same thing. In the ACC, they talk about an evidence of left ventricle diastolic dysfunction, and there are the new guidelines, ACC guidelines 2025. So I agree with Dr. Magdi, and you agree with me, that HFpEF diagnosis is challenging because HFpEF is very heterogeneous, because, as Dr. Magdi said, signs and symptoms are non-specific, because when we say that we have preserved ejection fraction, it is we are sure that it's a normal ejection fraction because it depends on age, it depends on sex, and also patients with HFpEF have many significant comorbidities. And for, as Dr. Magdi also said, for natriuretic peptides, they are often unreliable because they could be raised in some situation, for example, in case of advanced age, renal dysfunction, anemia, and especially for obese patients, as he says, patients with obese patients, even in 20% of cases, we can have HFpEF with normal natriuretic peptides. And especially in obese patients, we need to lower the cutoff level by up to 50%. So what can you do in this situation? And especially what is the role of echocardiography to confirm the diagnosis of HFpEF? Certainly, we needed to assess the left ventricle ejection fraction, but also to exclude conditions that mimic HFpEF. That means the secondary HFpEF. I come back to that. And we need also evidence of cardiac abnormalities at rest or with exercise. And I'd like to share with you another algorithm. Dr. Magdi shared with us a European one. It's interesting also, but this is the new one, the American Society of Echocardiography update of recommendation to assess diastolic function. And as you see here, we should do a good exam, a comprehensive echocardiography, exclude other causes of dyspnea, and then we should assess left atrium pressure. If we have elevated left atrium pressure, we confirm HFpEF. If we have dyspnea with left atrial pressure normal by wrist echocardiography, we should move to diastolic exercise echocardiography or right heart catheterization, and in this situation to explain this dyspnea. So echocardiography has a key role to confirm HFpEF. We should look to the left ventricle, to the heart, the left atrium, the left ventricle, and the right heart, the right ventricle, and the right atrium. And we should look for these, as I said, structural and functional abnormalities, left ventricle mass, left atrial volume, E prime ratio, this is for diastolic dysfunction, PA systolic pressure, TR velocity at rest. But I'd like to highlight the fact that we can have HFpEF without left ventricle hypertrophy. Left ventricle hypertrophy isn't constant, and we can have HFpEF without dilation of the left atrium. That means the structure is normal, but it can hide a function, abnormal functional function of the left atrium. And we also need, if we look here to the HFpEF score, other parameters, and there are major parameters and minor parameters. If we look here, we can, for example, here, minor parameter, left global longitudinal strain for the left ventricle is a minor parameter, but it could help us in our daily practice to confirm the diagnosis of HFpEF. For the functional abnormalities, it's the same slide that Dr. Magdi, we need 4 parameters: tricuspid regurgitation velocity, mitral annual velocity, mitral flow velocity, but also recently the left atrial reservoir strain, the strain of the atrium, and especially the reservoir function of the atrium, because it was shown that the change in the left atrium reservoir strain precedes the change in the left atrium volume. That's why we needed to assess the left atrium pressure and the left ventricle diastolic function, and also the left ventricle filling pressure. And they proposed the cutoff of left atrium global longitudinal strain less than 18% for the diagnosis of increased filling pressure. What is important also that the left atrium strain parameters was found as a continuous variable across severity of diastolic dysfunction. And despite image quality, obesity, COPE, atrial fibrillation, it works well even in atrial fibrillation with a proposed cutoff of 16%. And now we are talking about left atrial myopathy in heart failure, and even we talk about biatrial myopathy in HFpEF, especially in advanced HFpEF. So how can we, in our daily practice, assess left atrium pressure based on the new guidelines? We need 3 parameters: E prime velocity, E prime ratio, TR velocity, or PA systolic pressure. And then it depends. If we have the 3 above, we can conclude that to increase left atrium pressure. If or normal, it's normal. The problem is the gray situation, intermediate situation, when we have 1 of 2 of these parameters. In this case, we need the left atrium reservoir strain or the pulmonary vein SD ratio to conclude, to assess the left atrium pressure. And in these guidelines, they propose also offer us an algorithm to assess left atrium pressure in case of atrial fibrillation. It isn't easy to do it in our daily practice in case of atrial fibrillation. And we should, if our patient is still symptomatic, but rest echocardiography was normal, we need to go to stress echocardiography. And if we have ratio E prime more than 15, TR more than 3.4, at effort, we can conclude to heart failure. And recently, the new paper showed also the impaired myocardial work efficiency in heart failure in HFpEF. It could be interesting, another parameters that we can assess to have more parameters concluding for HFpEF. So, echocardiography is a key tool to assess left ventricle diastolic function, to assess also left ventricle ejection fraction, but we need, as I said, echocardiography beyond left ventricle ejection fraction. We need to determine another causes, as I said, of HFpEF, the cause of dyspnea, but also the phenocopies of HFpEF. Is it primary HFpEF or secondary HFpEF? Is it infiltrative cardiomyopathy such as amyloidosis or Fabry disease or hypertrophic cardiomyopathy? It's a second role, so it's very important to exclude secondary HFpEF before concluding to the primary HFpEF in patients who have many comorbidities and cardiovascular risk. And then what we call HFpEF mimics, for example, here for cardiac amyloidosis is misdiagnosed and underdiagnosed in Tunisia. We should think for it, especially in case of increased left ventricular wall thickness, but in the case of speculate myocardium, it's very important, or a gradient between the base and apex when we do the global longitudinal strain and strain. This is a typical aspect of amyloidosis, so before concluding to primary HFpEF, we should be sure that it isn't a secondary, and especially amyloidosis. What is interesting also for echocardiography, it can help us also to distinguish between constriction and restriction. That means between restrictive cardiomyopathy and constructive pericarditis. It isn't easy in our daily practice to distinguish between these entities. This algorithm is very interesting, especially E prime can help us, and especially annulus reversus between the mitral annular medial and the lateral E prime velocity. So I invite you to read these guidelines because they are very interesting. So echocardiography is compulsory. It's a key, as I say, tool to assess, to confirm the diagnosis of HFpEF, but it has limits, the limits of image quality, obesity, and Dr. Magdi said in 20–40% patients with HFpEF have obesity. It can reach even 80% of the patients with obesities. So we need, now echo is needed, but now I can that brings me to cardiac MRI. To talk about cardiac MRI, it's also interesting in this case to tissue characterization, especially to have an idea about etiology and to assess also the structure and of the different structure of the heart. Especially it shows fibrosis is a common histologic finding of failing hearts in the case of HFpEF. So we needed to orient us for the etiology. Is it cardiac amyloid or Fabry disease? It depends on the aspects in the MRI. It also offers us the possibility to diagnose segmental hypertrophy because we can miss the diagnosis of focal hypertrophy in echocardiography, and we need it in MRI. And recently, what's new now, we can assess the microcirculation in the cerebral microcirculation and the vascular macrocirculation, which is one of the mechanisms behind the HFpEF. We can demonstrate it by using MRI. And now we can't talk about imaging, MRI or echocardiography without EI. And now EI is very helpful for us to have quick assessment of the diagnosis of the etiology in this case. So for our patient, I think the diagnosis is clear, especially based on the clinics, but echocardiography, we have left ventricle hypertrophy, we have diastolic dysfunction grade 2, we have high left ventricle, high left ventricular filling pressure. So they have HFpEF, but I think what is different is the phenotype of these patients. And this is also a new paper, very interesting new paper, showing different phenotypes. The phenotypes here, for example, for our patient, this obese phenotype 3, the cardiometabolic heart failure, which is very frequent, should think to the diagnosis in cause of dyspnea. The phenotype 2 is especially the phenotype of older patients with high prevalence of atrial fibrillation. But in this case, we should think and we should exclude amyloidosis before, especially in the case of our second patients. So this phenotype is very important. I will introduce the next presentation because the phenotype-based approach focused on specific comorbidities should be considered in the treatment of HFpEF. We won't treat the two patients who have the same name with the same some comorbidities, common comorbidity. We don't treat them in the same way. It depends on the phenotypes to treat them, especially if they have secondary HFpEF. And this is also a nice paper showing how we treat HFpEF, SGLT2 inhibitor in the middle of the treatment, but we have the comorbidities, we should treat these comorbidities. So my take-home message are, HFpEF diagnosis can be difficult to make. Is it challenging? Echocardiography is, as I said, is a key tool to confirm the diagnosis. It gives left ventricle ejection fraction and much more. It helps us also to assess especially raised left ventricle filling pressure. The guidelines, the HFA or American, offered us many algorithms to simplify the approach of this entity. And I think that we need to, some may have many parameters, to especially concordant parameters, to conclude to the diagnosis of HFpEF. MRI may be helpful, especially for the etiology in some cases when the echocardiography, when we have the limits of echocardiography. And we should also think to the exercise test or cardiopulmonary exercise test when helpful in some cases. But don't delay, we just treat, and earlier is better even in HFpEF. Thank you for your attention, and like to invite you to save the date for TCT Plus Africa, which will take place in Tunis, the first edition, from 28 to 30 of January 2027. Thank you.
Thank you very much, Dr. Abid, for this nice presentation. And we invite the next speaker, our dear friend, Dr. Faiz Zanet, an expert, an international expert in heart failure. He talks about matching the right drug in obese patients.
So thank you so much for the invitation. It's always my pleasure, and the pleasure is even larger today because I'm welcoming my dear friend Marco as a local, because I'm in my country, Mark. We have traveled so much in many places, but today at least I'm so pleased to welcome you in my country. So you have seen so much sophistication about HFpEF, and indeed the pathophysiology of disease has erred into various directions, and certainly the factor of renal function, hypertension, vasodilation, a number of comorbidities and inflammation. And there have been lots of hypotheses which have been behind a number of pharmacological developments. And you see some of them, this was over the last 10 to 20 years. but none of these really worked well. So we really had to think twice and find another reason for HFpEF. And echocardiographers have developed a much sophisticated ways of looking at the disease, but didn't really help much finding a cure. And of course, we thought that it's just a complex disease of the elderly, so many comorbidities, so maybe you should focus on comorbidities, and you have seen this slide with the number of comorbidities, and hypertension and diabetes were many of them, and many more scientists have sophisticated the system in going into phenomapping, proteomics, and much complex science, and other phenotyping depending on what is the dominant scene of the reason of HFpEF. But simply, this disease is really all about obesity, all about obesity. So I would like really to make sure that you forget anything you have heard about MRI, echocardiography, sophisticated science, and just have a Taylor measuring tap. Just measure the abdominal waist to height ratio, not the BMI. I will explain you what, because this is really your best guess. Look at the epidemiology of disease. It has been strictly parallel to the epidemiology of obesity. Hypertension, coronary disease, of course they may contribute, but the biggest contributor is obesity. And then from the UK Biobank and the Framingham study, the very large epidemiological cohorts, when the focus is not on BMI again, when the focus in visceral obesity, whether it is measured by body fat mass or visceral fat mass, different techniques of imaging, or epicardial fat, look at that, the excess risk and certainly preceding progression to HFpEF. So the key dominant factor of progression to HFpEF is visceral obesity. And look at Paragon heart failure trial with sacubitril valsartan. This was HFpEF, one of the latest trials, where people were not necessarily enrolled on the basis of obesity, but when we evaluated how frequent was obesity, especially if you measure it with the waist to height ratio, you will find actually 95% of the patients had obesity, 95%. So this is a superimposition of the two diseases. Obesity and HFpEF are simply superimposed. BMI was very poor indicator. Now look at fine art, finerenone, the latest HFpEF trial. Also, patients were not enrolled on the basis of BMI whatsoever. And Paragon as well. And you can see the risk, cardiovascular risk, was strictly related to waist to height ratio. The best possible predictor of risk, much better than any echocardiography parameter, much better than any biology, and certainly much better, even including NT-proBNP. NT-proBNP retains its prognostic value, but you know that obesity had much lower level of NT-proBNP. So waist to height is key. And now when you get to pathophysiology, you can superimpose the pathophysiology of HFpEF and obesity. You can see a systemic inflammation, left ventricular hypertrophy, remodeling, and all pathophysiology you are familiar with in HFpEF. These are precisely under the control of excess fat. Now, Milton Packer has contributed over the last few months a number of papers in JACC, all focusing on obesity and the central mechanism of adipocytokines called adipokine. Adipokine is a very rich family of inflammatory factors, all of them produced in the adipocytes. And actually, it is a very large family. It does include aldosterone, for example. Aldosterone is produced in the adipocyte. And it does include a number of other factors, and all of them are hyperactivated in the wrong direction and are causative, not only associated, but causative to HFpEF. But again, you really need to focus on the visceral fat, not subcutaneous fat, which is biologically dominant. which is the most important pro-inflammatory fat, is the visceral fat, which you may not access only by weighing patient or the BMI, but you need to access either with imaging or, much simpler, by the weight to height ratio. Now, these are the seminal papers of Milton Packer. Really good reading, complex readings. I can tell you this is complex because I was invited to write a commentary about these papers, and I had to read them all, and I had really need lots of coffee to get around them. But these are extremely provocative because they would focus everything on the adipocyte, which is at the origin of multi-adipokine. One of them is aldosterone. One of them is also neprilysin. So it does explain the manufacture of aldosterone receptor antagonists and of secondary valsartan. And many other of them are yet to be targeted with new medication, and there is an intense research with anti-leptin therapy, anti-adipodectin therapy, and many anti-activin, et cetera. Now, of course, we have already SGLT2 inhibitors, which may oppose the alteration adipocyte biology, but the most important therapy is incretin-based drugs. And I will focus on that now. There has been a presentation of a very smallish study called STEP-HFpEF, which was an obesity study with HFpEF. And you can see that it indicated that the drug may be super effective on heart failure outcomes. But it was a very small study. There was a handful of events, 13 primary events, so we couldn't really be convinced about that until we got SUMMIT. SUMMIT was with tirzepatide, which is a dual glucose-dependent insulotropic GIP agonist and GLP-1 receptor agonist. And this was a randomized, well-powered study enrolling only patients on the basis of waist-to-hip ratio and obesity. You see 50% were women, and T-proBNP was low, 196 only, and these were all HFpEF patients. And some of them had poor renal function and the different features of HFpEF. Many of them were already receiving an MRA, and some of them were receiving an SGLT2 inhibitor. And you can see the main primary endpoint, which was time to first event for cardiovascular death or worsening heart failure, was significantly altered. Of course, P was only 0.004 because the numbers were small. You can see less than 100 events, so it's by no way it's a definitive trial, but it really strongly indicates that this class of drug may be the treatment of the future for HFpEF. 40% decrease in the primary event. And this was concomitant, of course, to a major weight loss, almost 10% decrease in weight. And this is no surprise because these medications are super powerful into making a weight loss. But more precisely, this was also very much behind the intense effect on inflammation as measured by CRP. So very strong anti-inflammatory effect. At the same time, not only weight loss, but it was loss in target organs, paracardiac fat, and left ventricular mass also decreased significantly in this trial, indicating that there is a clear path, a mechanistic pathway. So this is the mechanistic pathway, which is mitigated by a number of known medications already, whether it's neprilysin inhibitors, secondary valsartan, finerenone, mineralocorticoid receptor antagonists, SGLT2 inhibitors, more so when directly addressed by GLP-1 receptor agonists, which may slow the progression to heart failure if patients are starting this medication, whether because they are obese or with diabetes before they get HFpEF patient, but also when they are symptomatic. In the future, we are working on measuring adipokines and potentially a ratio between the favorable adipokine and the harmful adipokine, which is adipokine type 1 and type 3, which may predict the risk in HFpEF and which may guide therapy, but this is the future. So putting all the evidence together, the highest evidence, the most powerful effect was with this GLP-1 and GIP agonist medication. But we do have medication now for HFpEF. We hopefully have really made progress over the last only 5 years, right? Of course, we have sacubitril/valsartan, post-Paragon, empagliflozin, and dapagliflozin with the SGLT2 inhibitor trial and MRA. So we do have treatment, and certainly the most promising of them is tirzepatide. There are ongoing trials, larger trials with tirzepatide, the SURMOUNT MMO trial, morbidity, mortality, not specifically a HFpEF trial. It is a cardiovascular disease and cardiovascular risk trial, including HFpEF. Same thing in SOUL and SURPASS-CVOT trial, which is a trial with CKD patient or cardiovascular risk, including HFpEF. And there are many more ongoing research in order to understand the pathophysiology relating adiposity and HFpEF and the mechanism of the medication we have discussed beyond weight loss, and also the value of combination therapy. In the future, we will have to use this combination therapy, and whether there are specific subgroups which may benefit more from this targeted therapy. Thank you so much for your attention.
Thank you so much, Professor Zanat, for this excellent presentation. Now it's my pleasure to invite Professor Marco Metra. Professor Metra is a professor of cardiology at San Rafael in Italy, and he is the president of the Heart Failure Association, ESC, and now he's also the editor-in-chief for the new journal of the ESC, Valvular Heart Disease. So welcome, Professor Metra.
Thank you, Magdi. Thank you, Professor Leila Hamid. It's my second time in Tunis, this time with Fayez Zanat that is hosting me as well. Unfortunately, I never find the time to go out of the hotel, but I only have 2 minutes. So let's move ahead. Maybe, okay. These are my disclosures. Well, I had to change my opinion on HFpEF, or I don't know how much. I still don't know what to say. We started years ago with this heterogeneous phenotype of HFpEF, and of course we had obesity, as already shown by Professor Zanad, but we had also so many different comorbidities. But actually, most of the results were obtained in patients with obesity. But we had this hypothesis that already unified the pathogenesis of HFpEF, having the inflammation leading to a reduction in the production of soluble guanylate cyclase, and then fibrosis and hypertrophy. But then we came, as Fayez has already said, we are coming close to a unifying hypothesis of HFpEF, where obesity, or better, adiposity, is the cause of everything. And I will go further with this hypothesis based on recent papers by Milton Packer and also Fayez from this point of view. You have seen another figure from the same article, and this is the article by Milton Packer as only author, where he put forward this adipokine hypothesis of HFpEF. I'm not sure that this is the only cause of HFpEF, as Milton Packer is writing, but of course it has the advantage of simplicity in the end, and of unifying all the mechanisms. According to this hypothesis, HFpEF is mainly due to an unhealthy inflamed adipose tissue, with an imbalance between bad adipokines versus good adipokines, resulting in fibrosis, myocardial hypertrophy, and sodium retention at the kidney level. And there are some data supporting this. This is a paper which Professor Zanad co-authored, and it shows that if we consider the effects of anti-diabetic treatment and the effects of treatment on heart failure outcomes, paradoxically, the two classes of drugs that are most effective reducing heart failure outcomes, GLP-1 receptor agonists, and to a larger extent, sodium glucose SGLT2 inhibitors, they have a mild, or in the case of SGLT2 inhibitors, very mild effect on glycated hemoglobin, which is a target of anti-diabetic treatment, whereas they have a major effects on events. So the drugs may be active through mechanisms that are not dependent on diabetes improvement. This regards antihypertensive treatment, again from Milton Packer and Fayez Zanad. And what they did is to draw this inverse correlation where the largest effect of antihypertensive treatment on heart failure events was obtained in trials with patients who had the higher pretreatment body mass index. So you have more effects in these trials where patients had the highest, largest body mass index. Again, according to this hypothesis, again, antihypertensive treatment reduces heart failure events mostly through an effect on adipokines and adiposity. And this is the unifying hypothesis. I am not sure how much this is completely true, because I think we should need epidemiological data showing that all the patients with HFpEF have a visceral adiposity. We don't have this yet, but at least according to this hypothesis, visceral adiposity may be a major cause or the major cause of HFpEF, as well as insulin resistance, hypertension, and CKD. And obesity is frequent, actually. I took data from Tunisia, and I was impressed. We have here that 37% of adult women and 22% of adult men have obesity. There has been a major rise in the obesity rate from 18% to 27% in the last 15 years, and there is also growing childhood obesity. Therefore, it's easier in countries like ours, also Italy has same data, similar data. It's easier to find obesity as the major, if not the only cause of HFpEF. This you have already seen this slide from the Paragon trial, where you have that the prevalence of adiposity measured as a waist-to-weight ratio above 50, 0.5. So adiposity was found in 96% of the patients enrolled in Paragon HF. Here you see the relationship between adiposity as measured as body fat percent through DXA, and obesity as measured through the BMI. And you see that there are 25% of men and 48% of women who have adiposity despite a normal BMI. Therefore, it may be that when we have a patient with HFpEF in front of us, he or she may have adiposity with an high proportion. But the good news is that independent whether the patient has adiposity or only hypertension or only CKD, we have some common treatment for all these patients. And Fayez Zanad has already shown what is this treatment. There are at least 3 drugs that are effective in all the patients with HFpEF. The first category is SGLT2 inhibitors, which have been shown to be effective independently from the body mass index and with a larger effect on quality of life in the patients who have a larger body mass index at baseline. And this is a meta-analysis, and again, you see that the efficacy is independent of the body mass index at baseline. Regretfully, I don't think we can have the waist to hip ratio in these patients, or do you have? But it would be very important to have it. Then we have aldosterone antagonists, and I like to show this slide because when I was editor-in-chief of the European Journal of Heart Failure, I had to fight with the reviewers for the acceptance of this paper, which was probably the first paper from the Emphasis HF trial showing that the efficacy of eplerenone versus placebo in patients with heart failure and reduced ejection fraction was higher in the patients who had adiposity, an increase in the waist to hip ratio. Then later, we had this analysis, again in patients with HFrEF, showing a larger efficacy of eplerenone or spironolactone in patients with a larger body weight. And then we had this analysis in HFpEF with finerenone in fine arts, showing a larger effect on the combined primary endpoint as well as in total worsening heart failure events, but not in cardiovascular death with finerenone in patients with a larger body mass index. And last but not least, you have already seen the data. We know that GLP-1 receptor agonists have favorable effects not only on the body weight, but also on adipokines and also on inflammatory markers. And these effects were shown to be somehow body weight dependent in the trials with the semaglutide and tirzepatide, but however, at least with semaglutide, we have data in patients with diabetic nephropathy, not necessarily obese, showing an improvement in all the outcomes, including heart failure events. This is the analysis for heart failure outcomes in patients with diabetes and chronic kidney disease, not necessarily obesity, and there was a reduction in cardiovascular death and heart failure events alone. The reduction was found both in the patients with an history of heart failure and in the patients without an history of heart failure. And you see here that this efficacy was independent from the body mass index at baseline. Of course, we don't know if these patients with a normal body mass index had adiposity or not, but at least the good news is that irrespective of obesity or not, we have a treatment also for these patients with HFpEF and diabetic nephropathy. We have other, do we have other subgroups of patients with HFpEF and non-obese? Maybe. Hypertension, and I just wanted to point out one result. Of course, antihypertensive treatment was very effective in preventing heart failure events in patients with hypertension. I like this data that show that there are patients with so-called malignant hypertension where we have left ventricular hypertrophy and an increase in biomarkers, NT-proBNP and or troponin levels. These patients have a very high rate of events, and intensive lowering of blood pressure, as in the SPRINT trial, was shown to be effective in these patients, reducing the events. Another last few slides, and they have been already mentioned by Professor Hamid, is that we have also, we don't know if it is real, if this patient P2 also has some adiposity, maybe, but there may be a different phenotype of patients with, I think, the major finding is stiff arteries, poor arterial compliance, and these patients have a poor outcome. This is an analysis from TopCat. This is another analysis from the Barry Borlaug group, who also co-authored the articles with adiposity, but here you have these patients with high pulse pressure and with stiff arteries who have a poor outcome. There are at least some sub-cases in which identifying these patients may be useful. These patients often have pulmonary vascular disease, and at least in this trial, reduced lap with interatrial shunt, there was shown, it was shown an heterogeneity in the response to interatrial shunting, with a lack of improvement, actually a worsening in the patients who had latent pulmonary vascular disease and HFpEF, whereas there was an improvement in the patients without pulmonary vascular disease. Another group of patients that's coming to the forefront now are the patients with tricuspid regurgitation and HFpEF. This is a recent analysis, again, from the Mayo Clinic group, where the patients were classified based on the presence, again, of pulmonary vascular disease and HFpEF and tricuspid regurgitation. And you see that there was a different outcome depending whether the patients had atrial or ventricular pulmonary tricuspid regurgitation. Then, of course, we have the specific causes of HFpEF, amyloidosis, and hypertrophic cardiomyopathy. So I really cannot tell nowadays if everything is adiposity or not, with the exception of these specific causes of HFpEF, but at least we have 3 classes of drugs that are effective for the treatment of all the patients with HFpEF. Thank you.
Thank you, Professor Metra, for this nice presentation about the treatment that depends on the phenotypes of HFpEF.
Thank you. Thank for all the speakers. I think we are on time, and we move to the next session. Thank you.